Okay, good morning all. Today we are going to see about the gynecology. Okay, last day you have seen about the normal reproductive female reproductive system that you can see. I told you to study write an assignment regarding review of the anatomy and physiology of reproductive system. So I think you are all are familiar about that too. Female reproductive system, you have gone through that. So here we can see what are the developmental abnormalities of external genitalia. Okay, so the female, here first we can see the external genitalia abnormalities. Going to see about the congenital abnormalities. Today's topic is congenital abnormalities of female reproductive system. In that, first we are seeing developmental anomalies of external genitalia. Okay, so coming to the perineal or vestibular anus detected, that is the perineal or vestibular anus, that is the abnormality we can be detected at the time of birth. Usually anal opening site is evidenced by anal pit. Either anus will be situated close to the posterior end of the vestibule or in the vestibule. So in vagina, rarely congenital rectovaginal fistula. If this rectovaginal fistula means, that is the anus will be misplaced from the normal position. So we can say as congenital rectovaginal fistula. This rectovaginal fistula will be detailed, will be studied later. Opening is usually sufficiently big. Future reproduction, not a problem. If the rectovaginal fistula is also present, the reproduction is not a problem. Cesarean section advised in the future. Okay, so next is the ectopic ureter. Ectopic ureter, that is the additional ureteric opening is usually in the vestibule close to the urethra or in the vagina. Symptom: uncontrollable wetness. Partial nephrectomy and ureterectomy may be indicated, or implantation of the ectopic ureter into the bladder may be done. See, here is the figure has shown that the extra ureter can open into the vagina, urethra or the vestibule. Let's see. Then the vagina, here one that is the vagina, and the other vestibule, it's a extra opening is there, ectopic ureter. Okay, then coming to the vaginal abnormalities, that is the narrow introitus, that is the vagina will be the vaginal opening will be very narrow. A small opening will be there. So in later stages, in early stages all, we won't be recognized. After marriage only it will be recognized, during the time of coitus, or that is then revealed after marriage. Dyspareunia, you are familiar that, I think so. That is the painful intercourse, dyspareunia. Maybe the first complaint, or it may be detected during the investigation of infertility. Then treatment is effectively manual stretching under general anesthesia or by surgical enlargement. Then coming to the hymen abnormality, that is the imperforate hymen of significance abnormality, always unnoticed until 14 to 16 years. To 14 to 16 years we won't be recognized. Uterine functioning is normal. Menstrual flow is pent up inside the vagina behind the hymen. That is called as cryptomenorrhea. That is the we have seen told that we will be noticed only at 14 to 16 years. If the girl attains normal menarche, the attaining of normal menarche, that is the nowadays the girls are attaining menarche at 12, after 12 years onwards the menarche is attaining. So in case we if the family is looking after the attaining of menarche, and also up to 16 years old, 17 years maybe also the girl is not attaining menarche, we will go for further investigation. There we rule out this cryptomenorrhea, maybe due to the hymen abnormalities. That is the hymen, there will be the wall will be thick and the menstruation is attaining and it will be pent up out there and it will be cause cryptomenorrhea. Okay, depending upon the amount of blood so accumulated is the first distance the vagina, that is hematocolpos. That is the this every month it may be attained and it will be localized, that is the amount that the blood will be accumulated there and it will be distended and forms a mass like sometimes forms. So that is called as hematocolpos. Then the uterus is the next involved, the cavity is dilated. And also the uterus, that is the lining of the uterus and also some nearby areas also it will be dilated. So it is called as hematometra. That is the hematometra, we can say that is uterus pus sometimes. Okay, in late and neglected tubes may also be distended after the fibril ends becoming closed by adhesions, that is hematosalpines. That is the we are saying for the tube, that is the fallopian tube, another name we can call as salpins. That is the hematosalpins name comes. Fallopian tube, another name is salpins. So it has come extended towards the end of the this tube and there will be adhesions will be seen. So we can say that it is called as hematosalpins. Okay, understood about these terms? These terms they may be asked for one word. Now for your examination, that is the in KUHAS there is no one word and also you will be familiar about these words. Okay. Then clinical features that we have seen that age 14 to 16, periodic lower abdominal pain which may be continuous, primary amenorrhea, urinary symptoms. Then on examination, abdominal examination, suprapubic swelling, vulval inspection, tense bulging membrane of bluish coloration, rectal examination, bulged vagina. Okay. Then treatment. Cruciate incision is made in the hymen. Quadrants of the hymen are partially excised, not too close to the vaginal mucosa. That is, the first cruciate incision is made in the, we should be by crucial, small incision should be made on the hymen. And quadrants of the hymen are partially excised, that for whole quadrants of the hymen should be slowly excised, not too close to the vaginal mucosa. You should be very conscious about doing this procedure. Spontaneous escape of dark tarry colored blood is allowed because the blood is thickened, that is the hematometra, like that it is very dark color is accumulated. So we should be allowed that one. Patient should be made to lie down with the head and raised. Okay. Then next is the transverse septum above the lower 1/3. Usually comes earlier than the previous one with the septums placed higher and higher. Same presenting features but urinary symptom absent. Same surgical treatment. Here we can see fallopian tube, ovary, uterus, urinary bladder, urethra, rectum. So you can see the parts of that one, how it will be affected. Then septate vagina. Septate, that is the complete or incomplete longitudinal septum. And not a continuous. It is a complete or incomplete. It is complete or incomplete longitudinal septum will be there. Then may be associated with a double uterus or double cervix. May be asymptomatic or may produce dyspareunia or may obstruct delivery. Treatment, septum to be excised. That septum we should be cut off. You can see here figure, that is the septate. It is the uterus and this the cervix and how it comes. Okay, that vagina that comes. Then partial atresia of the vagina. A segment of vagina may be atretic in the upper third, may be associated with a cervical atresia, functioning uterus, usually primary amenorrhea, periodic pain in lower abdomen with a mass felt per abdomen or rectal examination point to the diagnosis. There is a partial atresia, we should be rule out this. Excision of the atretic portion from below and suturing the upper and lower margins of the vaginal walls are usually effective. Complete atresia associated with the absence of uterus, healthy gonads and fallopian tubes. Patient is phenotypically female with a normal karyotype pattern. Indate often associated with the urinary tract abnormality called Rokitansky-Koster-Hauser syndrome. That is the urinary tract abnormality. This is the one type of syndrome that will be occurs. Okay, understood about this is somewhat difficult. That is also other than that is the normal. We are seeing the gynecological conditions, so you should be thorough about this one. Already I have sent these topics PDF textbook. You may go through that and you can clearly identify that one. Okay, thank you.